Welcome to another deep dive with us. Today we're going to try to get into augmentation mastopexy.
Mhm.
And I think, as plastic surgeons, we all know this is a pretty popular procedure. It addresses two things that patients really want a lot,
Yeah,
which is more volume and less prostosis.
absolutely. It's kind of the best of both worlds for a lot of our patients.
Yeah. So we're going to be looking at a chapter from a pretty comprehensive medical textbook,
Okay.
and we're going to be talking all about augmentation mastopexy.
Right.
And so some of the things that we're hoping to kind of elucidate today are, why combine these procedures at all? When would you do one and not the other?
Right.
What are the things to think about before and during the procedure?
Yeah, we'll look at the nuances of, single stage versus two stage and how that's evolved over
Yeah.
time.
Cool. So to start off, how does this chapter define augmentation mastopexy?
I think it does a really nice job of kind of highlighting that it really addresses what the patients are looking for, which is that volume deficiency and emetosis. So it's really kind of hitting both of those desires.
And it's interesting, too, because, we talk about cytosis, and the chapter brings up the Regno classification.
Yes.
Can you kind of remind us what that is?
Yeah. So the Renew classification really is just a way to grade the cultosis.
Yeah.
And so, grade 1 is that mild ptosis, where the nipple is at the inframammary fold. Grade 2 is when it falls below. And grade 3 is where the nipple is the most inferior point of the breast. So that's your most severe cytosis.
Right. Okay. And they also talk about pseudoptosis in here.
Yes.
And I know that's something that has kind of like tripped me up before
Yeah, it can be a little bit tricky.
because it almost looks like there's no doptosis,
Right.
but there is.
Yeah, so the nipple can actually be at or above the inframammary fold, but you'll see that the breast tissue itself descends below the inframammary fold.
Right.
So it's kind of that hidden mitosis.
Yeah. So when do we decide, augmentation alone versus mastopexy alone?
Yeah, that's a great question.
There's kind of a line.
There are some specific situations where one or the other may be indicated. So for example, if a patient has very minimal skin excess, meaning there's not a lot of breast tissue hanging below the IMF, and very minimal contosis, augmentation alone may suffice.
Okay.
And the added volume from the implant can actually provide enough lift to give them that more youthful appearance that they're looking for.
So it kind of does the work, the lift as well.
Exactly. And then on the other hand, if you have minimal volume deficiency, but significant mactosis, then a mastopexy alone may be all that's needed.
Okay.
So, you remove the excess skin and reshape the breast, and that achieves the lift without adding volume.
Okay. So that makes sense for those two individually.
Yeah.
But what about the single stage versus two stage? This is always kind of a hot topic.
Yeah.
And they talk about that in the chapter.
It is. And I think it's interesting to see how it's evolved over time. So, initially, the single stage procedure had a little bit of a bad rap. It was considered to be unpredictable, had high revision rates, and even a higher rate of malpractice claims. So surgeons were a little hesitant to adopt it widely.
Yeah, that makes sense. It's a
Okay.
more complicated procedure.
Right.
But it seems like they're saying that things have changed a little bit.
They have.
Yeah.
Yeah. So with advancements in techniques, implant technology, and also in patient selection, the single-stage approach has gained wider acceptance. And it's considered to be a safe and reliable option for the right patients.
Okay. Well, that's good because a lot of patients I know would prefer one surgery over two.
Oh, for sure.
So what are some of the red flags then that would make us think we need to do two stages?
Yeah. So there are some contraindications to doing a single-stage augmentation mastopexy. And those include things like, first we have to look at the skin envelope. Is there any constriction or deficiency? Because if there is a single stage, may not be the best option.
Right. You need enough tissue.
You need enough tissue to work with.
You get where you're going.
Exactly. And then we also have to determine if both procedures are truly necessary. So if the patient has minimal pressus and minimal breast tissue below the IMF, they may not even need a mastopexy at all.
So you're saying sometimes augmentation alone might be enough?
Exactly. And the chapter even mentions that if the nipple to IMF distance is less than 10 centimeters, then a mastopexy may not be indicated.
Okay.
And then another thing is significant asymmetry. So if we're dealing with asymmetry, that requires an asymmetrical mastopexy to correct a single stage may be too complex.
Okay, so too many variables
Right.
makes it less appealing.
Exactly. And then finally, excessive vertical skin excess is another red flag.
Yeah.
So if we need to remove a large amount of skin to achieve that lift, a two-stage approach might be safer.
Okay.
It allows for better tissue healing and potentially a better outcome.
All right.
So
So
those
that,
are some things to think about
yeah.
when you're considering single stage versus two stage.
Okay, great. So those contraindications are really helpful in deciding single stage versus two stage. But let's say we decide to do two stages. How do we decide which one to do first? Mastopexy or augmentation? And they talk about something called the tissue triad here.
Yeah, the tissue triad is a very important concept, and it's something that you want to look at whether you're doing a single stage or two stage procedure. And it really involves looking at three measurements.
Okay.
One is skin stretch, two is your nipple to IMF distance, and then three is your vertical excess.
So you use those measurements to help guide you.
You use those measurements to guide you. And so, for example, if the vertical excess is over 6 centimeters, oftentimes two-stage procedure is recommended.
Okay.
And then within that two-stage procedure, the primary goal will dictate the order. So if correcting the abortosis is the priority, then the mastopexy takes the lead. But if the patient is primarily concerned with increasing the projection or the fullness in the upper pole, then you might consider augmentation first.
Okay. So it just really depends on what the patient wants.
It depends on the patient and their goals.
Okay. Before we get into the actual surgery itself, I'd love to hear your thoughts on pre-op evaluation. What are some things that we really want to emphasize to patients?
Pre-op evaluation is really important. I think it lays the groundwork for a successful outcome. And I think it's important to really understand the patient's goals, manage expectations realistically, and then ensure that they're fully informed about the procedure and any potential risks. And, we need to have these open and honest conversations about things like potential asymmetry.
Right, because even if they don't have perfect symmetry, they may have gotten used to it.
Exactly. And so, sometimes the surgery can actually bring any pre-existing asymmetry to the forefront. And so it's really important to have that discussion.
Yeah, I've seen that happen.
Yeah. And then we also need to be transparent about the potential for reoperation. The chapter cites studies showing reoperation rates for augmentation mastopexy
Right.
range anywhere from 8 to 20%. So it's important that patients understand that, that's a possibility, even when everything is done meticulously.
Right. So transparency is key.
Transparency is key.
All right. So let's get into surgical planning.
Yeah.
And they talk about this tissue-based planning. What is that?
Yeah, so tissue-based planning is really all about precision and using meticulous measurements to kind of guide your surgical approach and implant selection. So we're looking at things like skin stretch, which tells us about skin laxity, nipple to IMF distance to look at our vertical dimension, vertical excess, meaning how much skin and tissue we're going to be removing, and base diameter, which helps us with our implant choice.
So those measurements are creating the roadmap
Exactly.
for surgery.
And one crucial tip that the chapter highlights is to always place the implant before making the skin resection incisions.
Okay. Why is that so important? It seems counterintuitive.
I know, right? It seems counterintuitive. But the reason for that is to avoid any surprises and make sure that we achieve that desired lift without removing too much skin. Because if you make those skin incisions first and then put the implant in, you may find yourself being skin short or needing a smaller implant than you initially planned. So putting the implant in first allows you to really see how the tissues drape and make those adjustments as needed.
So it's like trying on the dress before you alter it.
Exactly.
Right. So that makes a lot of sense.
Yeah, I think that's a really important point.
Okay. So we've talked about the importance of measurements and placing the implant before we do anything with the skin incisions. Let's talk about incision choices. What are some of the options and what helps us decide which one to use?
Yeah, so your incision choice really depends a lot on the degree of itosis that you're dealing with. So for minimal itosis, where the nipple is, less than 2 centimeters, below the IMF and there's not a lot of skin excess, the periolar incision can be a great option because it allows for a nice lift with minimal scarring. And it's especially suitable if the nipple areolar complex is well positioned and doesn't need a ton of repositioning.
So that's for less severe cases.
One less severe cases.
What about more severe?
For more severe cases where there's more itosis, then you have other options. So if there's a lot of horizontal skin excess but minimal vertical excess,
Right.
Kind of that stretched out look, then a vertical incision might be the way to go. And that just runs straight down from the bottom of the areola towards the IMF. And then if you have both vertical and horizontal excess to address, then you might consider the Wise pattern incision, which is named after Dr. George Wise, who was a pioneer in breast surgery. And that's been kind of the workhorse for addressing more significant metosis.
You've got those three main options.
Three main options.
Okay. And now let's talk implants. Silicone versus saline, subglandular versus submuscular. So many choices. What does the chapter say?
Yeah, it's a lot to think about. And when it comes to implant material, the chapter acknowledges that it often comes down to patient preference and surgeon experience.
Hmm.
Both silicone and saline have their pros and cons, and the best choice really depends on the individual patient, their anatomy, and their comfort level.
Right. I think it's all about having that discussion with the patient
It is.
and making that decision together.
Shared decision making.
What about placement, though? Do they lean towards one or the other?
They do highlight that there's an increased risk of complications with subglandular implants,
Mm.
especially when you're combining it with a mastopexy.
Why is that?
So, when you think about a mastopexy, you're doing a lot of dissection. You're disrupting the soft tissues.
Yeah.
And so when you put an implant subglandularly in that setting, you're increasing the chances of things like implant visibility rippling or capsular contracture.
Because it's closer to the surface,
Because it's closer to the surface.
to those tissues that have been disrupted.
Exactly. So submuscular placement, on the other hand, provides a more stable pocket for the implant. And it kind of puts that protective layer of muscle between the implant and the healing tissues.
Okay. So that makes sense.
Yeah, so submuscular placement is generally preferred in augmentation mastopexy to minimize those risks.
All right, so let's go to the OR. We've got our incision, we've got our implant. We're ready to go. What are some intraoperative pearls that this chapter kind of imparts?
One of the big things they emphasize is meticulous technique throughout the entire procedure. So careful marking precise dissection and ensuring adequate hemostasis at every step. Those fundamentals are key to minimizing complications and achieving optimal outcomes.
Those are the building blocks of good surgery.
Yeah, those are the basics. And then there are those little details
Hmm.
that can make a big difference, like using tailoring tacks to help determine the final skin excision
Oh,
and prevent any over-resection.
and tailoring techs are great.
Tailoring tacks are so helpful. They allow you to visualize how those tissues are going to drape and make sure that you're achieving that lift without going overboard.
So you don't cut too much.
You don't want to cut too much.
Right. So meticulous technique, tailoring tacks, and then, of course, remember that we're putting in the implant before we do the skin incisions.
Exactly.
I feel like we were so focused on the implant that we kind of glossed over the plane a little bit. What about the plane?
Oh, yeah, that's important. So speaking of implant placement, we can't forget about the importance of selecting the appropriate surgical plane. And the chapter seems to really like the dual plane technique for augmentation mastopexy.
Why is that? Why the dual plane?
Well, the dual plane kind of offers that balance between the advantages and disadvantages of both subglandular and submuscular placement. So it involves placing the implant partially under the pectoralis muscle and partially beneath the glandular tissue.
So best of both worlds.
Exactly. You get some of the coverage and support of the submuscular plane while also allowing for a more natural look and feel in the lower pole. So it's both aesthetic and functional.
Right. It hits both of those.
But is the dual plane always the way to go?
Not always.
Okay.
The choice of plane really depends on the individual patient and their anatomy.
Mm-hmm.
So factors like breast tissue thickness, degree of sectosis, and their desired outcome can all influence your decision-making.
And I imagine surgeon preference plays into it too.
Surgeon preference definitely plays a role as well. Some surgeons have their go-to approach based on their experience and their comfort level.
Right.
But ultimately, it's about choosing the approach that's going to best achieve the patient's goals while minimizing the risks.
It really highlights how complex this procedure is.
It is complex.
It's not just putting an implant in and doing a lift.
It's not just a one-size-fits-all approach.
It's about understanding the tissues,
It's nuanced.
the planes, the techniques.
And it demands a deep understanding of the anatomy meticulous planning and a mastery of surgical technique. All right, so let's switch gears and talk about potential outcomes and complications.
Yeah,
What can patients expect?
sounds good.
Okay, so we've talked about patient selection, surgical planning, the nitty-gritty of the OR. But what about outcomes and complications? What can we really tell our patients?
Well, when it's done right, augmentation mastopexy, it can really be transformative for these patients. They get the volume they want, a more youthful contour,
Yeah.
just a whole new level of confidence.
Yeah, that's what we want. But, the chapter talks about reoperation rates. And as surgeons, we all know that those conversations can be tough.
Yeah, for sure. And I think it's important to be upfront with patients about those possibilities. There were several large studies cited in the chapter, and they showed reoperation rates anywhere from 8 to 20% for augmentation mastopexy.
Wow, that's a pretty big range.
Yeah.
What contributes to those reoperations?
Well, I mean, a lot of it can stem from the implant itself, malposition capsular contracture, even rupture in some cases. And then there are tissue-related complications too. Unattractive scarring, recurrent silicosis, nipple malposition, asymmetry.
So it's a mix of implant and tissue related.
Exactly.
And even though we try to be meticulous,
Of course.
there are some inherent risks.
Absolutely. And the chapter actually breaks it down even further, talking about complication rates for specific things. Hematoma, seroma, infection, loss of nipple sensation.
So even with good technique and planning, things can happen.
Exactly. And that's why those pre-op conversations are so important, shared decision-making. Patients need to have realistic expectations and understand both the benefits and the risks.
And speaking of expectations, I thought it was interesting that they said single-stage and two-stage procedures actually have comparable outcomes and complication profiles when patient selection is appropriate and the surgical technique is good.
Yeah, that's a really important point. I think it highlights that individual decision-making. We shouldn't default to one approach over the other. We have to really evaluate the patient, look at their anatomy, and consider their needs.
It's about the right approach for the right patient.
Tailoring it to their circumstances.
Well, this has been a really great deep dive. Augmentation mastopexy. It's a complex procedure. It requires, both an artistic eye and a scientific mind.
For sure.
And I think the chapter really drove home the point that this procedure is constantly evolving. Our understanding of breast tissue implant technology, it's all changing.
Yeah, and I think that should really inspire us to keep learning, evaluate our techniques, stay up to date on the research, and just really strive to get better outcomes for our patients.
So as we wrap up, I'd like to leave you with a thought. How do you think augmentation mastopexy will continue to evolve? What innovations or refinements might we see in the future?
That's a great question. It's something we should all be thinking about.
And as you face those challenging cases, remember what we talked about today. Careful planning, good patient selection, respecting the tissues, and never stop learning.
Those are the keys.
Well, thanks for joining us for this deep dive into augmentation mastopexy. We hope you found it helpful. Until next time, keep those minds curious and those scalpels sharp.